Dementia, though, obviously is that slow erosion of their personality and their thinking, their memory, their everything. They lose themselves with dementia, and it breaks my heart. And this is part of, I saw it happen with my mother-in-law, and it did break my heart because she was fun. She was a funny lady. She was I loved her. She's my mother-in-law, but I loved her, and to see her completely like change to somebody she wasn't, I don't want that for anyone. And if it's preventable, which it is, and you have power over it, and you don't have to wait for the system to catch up, because believe me, the system knows and has tried and has proven they can do it. They just don't have the infrastructure to do it. Why wouldn't you do it? Why wouldn't you protect your brain? Surgery may be necessary, but if you can do something to build your resilience and protect yourself, why wouldn't you? That's my whole message.
That's my whole podcast platform and my whole online platform is to build resilience and to avoid frailty at all costs, because you don't know what you're going to have to walk into.
Correct.
And you don't know if it's going to be something. Is it an alternative or a surgery you can have an alternative to? Do you have to do it right now? Do you have to do it later? Is it an emergency? And I want to be prepared.
Right.
And I don't want to come out the other side less than I went in. My biggest fear in the world is losing my brain, because it's all like you. It's, I mean, that's what we function on, right? That's how we make our living. And
it's who you are.
Yeah.
So you could be walking around a shell of yourself dependent. I mean, we don't want to lose ourselves.
So if folks go in with dementia, like that low key,
oh yeah,
it's so weird because in the medical world, I see low key dementia and low key frailty, and it's never charted. It's never acknowledged. It's just been normalized.
Yeah.
My mom's entire medical chart going through that, I had access to it on the back end, and not once did somebody mention frailty. And I'm like, are you kidding me? Like, to me, that's a vital sign for everything that we're going to do and everything that she's going to be able to handle moving forward is what is her, musculoskeletal state. And I mean, your muscle mass is a vital sign.
It is.
And there was no discussion of even post-procedure cognition.
Right.
So not necessarily delirium, but like anything. It was so weird to me about how little emphasis they put on even the ability to get up and use the restroom by herself. Like that to me should have been something that was charted daily.
Yeah.
As just a baseline of like, okay, we've got improvement. And none of it was. And I feel like it's almost intentional.
It's a system problem where there's not a code for something. There's not a motivation for it. I'm trying to phrase that properly. There's no code for postoperative management. So you can't capture any, and you can't give it to anybody to do. You can't assign the duty. Anesthesia is the one that's responsible ultimately for like, how do we optimize the situation? I'll give you an example of that in a minute. But the positive impacts are felt by other people. And it's really not inside the realm of anesthesia's scope of practice to be able to manage the infrastructure it needs to build to be able to, properly provide that. We were saying this earlier, like pre-op is your primary care doctor or cardiologist clearing you for surgery. Anesthesia is really concerned about keeping you alive, keeping you safe, keeping your blood pressure good, making sure you don't have a stroke, making sure you don't have a heart attack, making sure everything is really, really smooth. You don't wake up throwing up, having pain. Like we do care. Anesthesiologists, the whole specialty is very research focused and always looking for a way to improve safety, kind of like the FAA. But that's the limitation of where it stops. Afterwards, it's the surgeon you're following up with, and there's no one assigned to that infrastructure. And the interesting thing that you said, there was no cognitive question there. The Wall Street Journal published an article in 2016 saying brain measurement is coming. Brain measurement to preoperatively is coming, 2016. And that was because it was piggyback on the body of research we already had saying cognitive reserve is a problem. If it's low cognitive reserve, then we have more of a risk. And what medicine is really good at is identifying a diagnosis and a risk. So what we have when it comes to testing is cognitive assessment tests. Your neuropsychologist or your psychologist, they're going to do a cognitive assessment, mini-cog, all these things, MoCA scores, all that. That gives you a score of where you're at, okay? that's not giving you anything modifiable. It's just saying you're below baseline, you're at risk. And that's what they were talking about. And they understood that if you had a low score on these tests, that you would have a higher risk after surgery for delirium dementia. 10 years later, we did a study that polled 1,700 anesthesiologists and asked them, how many of you guys see cognitive assessment tests in your patients pre-op? 1 in 10.
Wow. So and that would be on the physician who's
looking,
clearing them for surgery.
No, it was the anesthesiologist looking at the patient, so we see them pre-op. We see them the day of surgery.
Oh, I see. Okay. You do see them pre-op generally?
Yeah.
Okay.
And within the people that they normally took care of, 1 in 10 reported seeing. 1 in 10 anesthesiologists reported seeing a cognitive assessment of any sort preoperatively on a patient that was even considered a high risk, 65 and older. So that's pretty significant given the fact that 10 years before that, actually 17 years before that, right? The New England Journal of Medicine in 1999 published that study that we were talking about earlier. It was done by Yale, and it basically took a population and that was at risk, 65 and older, and it looked at them and said, okay, we're going to take a multidisciplinary approach following surgery. We're going to give you light. We're going to make the environment better. We're going to give you massages instead of sedative pills. We're going to get literally that kind of stuff, like nutrition. We're going to follow the nutrition. We're going to really focus on these things in this population. They dropped delirium 40% in that population. 40%. This is a study in 1999. I want you to emphasize that because they already knew then that if we did these this is just post-op. This is not, we didn't even talk about preparation. We're just saying if we do that, we're already improving scores. They showed an economic impact of $7.3 million in the 90s, like cost savings for a hospital. That's a large incentive. And so it goes to show you that even if you have the data to support it, it's in the New England Journal of Medicine, you have economic benefits that are proven, the infrastructure is still not, you're not going to scale a change like that in the infrastructure because of the limitations of the system.